4.5 million people in South Africa have diabetes. The condition is known as a silent killer if it's not treated and managed properly. Well, most patients receive their treatment from primary healthcare facilities, but sometimes clinics are congested and patients have to wait in long queues to receive their medication for the month. Well, how can this challenge be addressed? Let's try and find some answers now with Patrick Ngasa-Piote from the Tshwane Insulin Project. Patrick, a very good morning. Thanks so much for your time. So let's start off first with where we're actually going wrong in terms of our treatment, in terms of helping our diabetes patients actually manage their condition. Where are the gaps in our system?
Okay, thanks for the opportunity. Yes, diabetes is, as you said, is quite a common disease, and all over the world, the management of diabetes is deemed quite complex. So in South Africa, yes, most patients will access healthcare in public care facility. The good thing is all the medication that we need are actually accessible for free, and even insulin, and that is already a win for South Africa. But however, we still see certain gaps in terms of ensuring that the patients are controlled. For example, in our study, we looked at a specific group of patients. Those are the ones that were deemed controlled and therefore were put under a certain system whereby they will receive their medication once a month from any location of their choice in order to avoid congestion of facilities. Unfortunately, that program has certain gaps that we highlight in our research.
Well, just looking now at where we are, and especially with COVID-19, especially with diabetes, a comorbidity, making those patients even more vulnerable now to COVID-19. Just tell us what has happened over the past year or so. How has this entire situation affected people in terms of getting access to their medication, in terms of their safety, and trying to get to these facilities to actually get their medication and get their treatment?
Yes, you are right. The COVID-19 situation has really highlighted the need for us to look closely into our people with diabetes and their care, and has highlighted obviously some gaps and some failure of the system. You can imagine with the regulations and the COVID-19 restrictions, the patients were requested to stay away from the facility as much as possible. Some have received 3 months or 6 months of medication. The problem with a disease like diabetes is that patients should first be empowered into making the right decision, allowing him or her to be part of the diabetes care team. But in our context, our patients don't have that level of education, they don't have that level of empowerment. So as a result, we've sent patients at home which control were quite suboptimal. And then, because they are unaware of it, because they are sometimes unaware of what to look out for, there have been aggravation in their control. And in this specific program, we found that even the identification of or selection of patients that are gene controlled was problematic. The test used by the facilities is the fasting plasma glucose. But all over the world, the gold standard is the hemoglobin A1C or HbA1c. So therefore, one of our recommendations is really to change those selection criteria for this specific program, and overall to have a closer look into our patients and how they are managing education of patients, and empowerment is therefore very key.
All right, so let's talk solutions. You've mentioned one of them in terms of closing those gaps that you've identified, tackling those gaps, because the situation, as we see fears of a third wave, Patrick, we know that this will remain one of the most vulnerable groups. So what do we need to do, and how urgently do we need to do it?
It's quite urgent. It's as urgent as yesterday. So basically, for the program, the criteria needs to be changed. We would even advocate for an assessment of all those patients that are on the system, because the control, we say they are controlled or stable, but we cannot make that statement using the test that was used. So there should be some sort of assessment of the whole patient, the whole cohort of patients on the program. And we need the health professionals, the health managers needs to find innovative ways to educate patients on how to take care of their disease, how to take care of themselves. It's very important because diabetes is a chronic condition. It's a lifelong condition. The patient needs to know what is entitled to request, the quality of care he or she is entitled to, that will obviously put a better rapport between the patient and the health professionals. So we will say basic things. Key things is to ensure that all patients are controlled. We are advocating for a test HbA1c to be done once a year, preferably in the beginning of the year, basically to find out where is your patient, how well is your patient controlled. And very important, to act on the results of the HbA1c, meaning if the medication needs to be changed, to change the medication, and to find innovative ways to really empower and educate our patients.
And I think that needs to extend, as we're seeing, Patrick, in terms of vaccine registration, for example, in deeply rural areas where people have no access. They don't have access to this kind of information. So does the program extend all the way there? Does it help the people who absolutely have nowhere else to turn to?
What you mentioned is very key. As we know, the South Africa is quite a wide territory, and most of the area will only have access to a nurse. Yesterday, indeed, even WHO was praising the role that the nurses played. It's very important for the government to take cognizance of the fact that our healthcare providers, especially our nurses, should be empowered. Therefore, once a patient or a person living with diabetes will be in contact with a nurse anywhere in the country, they will be able to have access to quality care, even in these circumstances of COVID-19. It's very important to have our healthcare providers up to scratch in terms of the diabetes management guidelines, and to roll out some sort of programs to educate our patients. I will not emphasize it enough. Education, education, education. You will imagine when you see the people living with HIV, with all the noise that has been done, all of them know what is a viral load, what are CD4 counts. But when you compare with our people with diabetes, it's completely different. They don't know what danger they could be faced if they don't adhere to their treatment. They don't know what is the HbA1c. They basically are left in the dark, and we need to change that situation.
All right, thanks very much. And yes, of course, the lifestyle changes that come with it. Dr. Patrick Ngasepioti there from the Tshwane Insulin Project. Diabetes needs to remain at the forefront, also right up there with COVID-19 at the moment. Still